Our next speaker is Margo Thelander, who is a board-certified genetics counselor with John Muir Health. Margo, welcome.
Thank you. It's a pleasure to be here this evening. Can everyone hear all right? So Dr. Lerner and Shen have spoken a bit about diagnosis and treatment of gynecological cancers. In genetic counseling, we focus more on the prevention of cancer, especially in people who have inherited a predisposition to specific cancers and who may have what we call a hereditary cancer syndrome. So people are usually referred to a genetic counselor because they or their healthcare practitioner has noticed a pattern of cancer in the family, or perhaps because they were diagnosed at an unusually young age, or perhaps they've been diagnosed with more than one primary cancer. Some of these patients have what we call a hereditary cancer syndrome. And these syndromes are usually caused by a single genetic factor that can be identified with genetic testing. So you're probably wondering, why on earth would anyone want to undergo genetic testing to find out they're at high risk for a potentially life-threatening disease? And the reason is that there are often preventive measures that can be taken to eliminate the risk or increased surveillance for early detection and a much better outcome. So these effective measures to prevent cancer can be extended to an entire family once an individual has been diagnosed with a cancer syndrome. So through genetic testing, we can discern which family members are at higher risk and can take advantage of these preventive measures, and which family members can gain some peace of mind knowing that they just have the normal general population risk. So here we see a pie chart that categorizes all cancers as either sporadic, familial, or hereditary. As you can see, the largest piece of the pie are not hereditary. They're the sporadic events that occur by chance or due to environmental factors. There's no history of that type of cancer in the family, and they usually occur later in life. About a quarter of individuals who've developed cancer do have a family history of the same kind of cancer, but the underlying cause is not a single genetic factor. It's more likely to be multiple factors, either environmental or chance, each factor contributing little to risk. So we call these, we say these patients have familial risk for the kind of cancer that's running in their family. And familial risk, of course, the degree of risk it changes with the number of affected family members and how closely related they are to you. So having a third-degree relative, a cousin with cancer, or a couple of cousins with cancer, is not going to give you nearly as much familial risk as if you had a sister and a mother, for example. But familial risk can double or triple your general population risk. The smallest piece of the pie, or about 10% of cancer patients, have an inherited mutation in a single gene that causes a hereditary predisposition to specific types of cancer, or what we call the hereditary cancer syndrome. These patients usually have multiple relatives with cancer, with one or more diagnosed at an early age, and sequential generations are usually affected, and some of the family members could have multiple primary tumors. For example, this slide shows a family history, or what genetic counselors call the pedigree, of one of the patients I saw last week, and it has all the signs of a hereditary cancer syndrome. My patient was the woman, let's see here, whoops, go back. Okay, whoop, okay, let's get this. Okay, press the red button. Okay, this was my patient, the woman at the bottom with the endometrial cancer diagnosed at 59. She has 2 siblings with colon cancer. a father with colon cancer, 2 paternal uncles and a paternal aunt with stomach, colon, and ovarian cancers, respectively, and a paternal grandmother with endometrial cancer. So the individuals who have cancer are all blood relatives in sequential generations. So there does appear to be an inherited predisposition that follows what we call a dominant pattern of inheritance. It's just going through one bloodline. So the purpose of genetic testing in a family like this would be to find out if these cancers have a common underlying genetic cause in the form of a genetic mutation. If a mutation can be found, this allows members like my patient's 45-year-old unaffected sister to find out if she inherited the family mutation and should take proactive measures to avoid developing the cancers seen in her family. Or if she does not carry the mutation, she can gain some peace of mind in knowing that she has the same risk as the general population in spite of her strong family history of cancer. So this slide shows some of the cancer syndromes I see in my work. In a cancer syndrome, as I mentioned, a single genetic mutation is increasing the cancer in multiple parts of the body. The individual who has one of these syndromes may develop cancer in only one part of those parts of the body, in more than one site, or not at all. And this, of course, depends on whether or not any interventions are taken to reduce or eliminate the chance of cancer developing. One of the things you may notice on this slide is that a given type of cancer, such as ovarian cancer or endometrial, occurs in more than one of these syndromes. So that's why it's really important, if you're going to visit a genetic counselor, to obtain a really accurate family history, to know exactly what the diagnosis was for each family member. For example, you may just hear that your aunt had a uterine cancer, but there's a huge difference to a genetic counselor between a cancer that develops in the endometrial layer of the uterus as opposed to a sarcoma that develops in the muscular layer of the uterus, in terms of what cancer syndrome we might test for. So as much as you can get a good family history, that's important. So I'm going to talk a little bit about these first 2 syndromes because they're more common than the others and because they both increase the risk for gynecologic cancers. The cancer syndrome that gets the most media attention is the hereditary breast and ovarian cancer syndrome caused by the BRCA1 and 2 genes. But it may surprise you to know that the second syndrome listed, LYNCH syndrome, is twice as common as hereditary breast and ovarian cancer, yet is much less often recognized. LYNCH syndrome is associated with high risk for both colon and uterine or endometrial cancers, and moderate risk for ovarian, ovarian cancer. But all 3 of these cancers are highly preventable once the syndrome is recognized in an individual. LYNCH syndrome was previously known as hereditary non-polyposis colorectal cancer syndrome. Quite a mouthful, because the colon cancers are not usually associated with a lot of colon polyps. But the name was changed to reflect the fact that gynecological cancers are a major part of this syndrome, as was initially recognized by Dr. Henry Lynch. People with LYNCH syndrome are at high risk for colon and endometrial cancers, of course, depending on their gender, and moderately increased risks for ovarian, stomach, and upper urinary tract cancers. The risk for the other cancers you see on this slide, such as small intestine, biliary tract, pancreatic, and sebaceous gland cancers, we know the risk is increased over the general population, but in many families with LYNCH syndrome, we don't see any of these. So we just say that it's increased but varies tremendously from family to family. Like the other hereditary cancer syndrome, LYNCH syndrome is caused by a single genetic mutation that can potentially affect multiple parts of the body and is passed down through successive generations. For males, we see up here 80% lifetime risk for colon cancer. It's actually, that's the highest risk for males, and the colon cancer risk is a little lower for females, so that the risk for colon and uterine is about equivalent for females. And so about half of women who are diagnosed with Lynch syndrome have a uterine cancer and not colon, at least at first. And hopefully the diagnosis is made before they have to develop anything else. So, of course, if a woman knows she has Lynch syndrome before a diagnosis is made, then there are very effective preventive measures she can take so that she never develops either colon or uterine cancer. It's recently been estimated that about 600,000 people in the United States have Lynch syndrome, and only about 5% are aware of it. So it's one of my pet projects to raise awareness about Lynch syndrome. So going back to this pedigree from before, now you can probably recognize that this patient has Lynch syndrome. The way we go about identifying people who have Lynch syndrome usually begins by looking at the family history and recognizing the characteristic cancers in the family, although this can be really difficult if the family's small. We may just see someone diagnosed with colon or uterine cancer at a very young age. They may be an only child or have very small families on both sides. So family history is not always the most reliable stage. There are 4 different genes that can be involved in this syndrome. So we usually, if we have any suspicion for Lynch syndrome, we'll, when the cancer surgery occurs, we'll do some testing on the tumor tissue, and by looking at the proteins in the tumor, we can get a good idea which of the 4 genes may be involved. And from there, we do genetic testing on a blood sample of the person to try to find the genetic mutation causing Lynch syndrome. Knowing what the genetic defect is then allows any other family member, whether or not they've had cancer, to test for that mutation and see if they also have high risk or not. If they have high risk, then we have special recommendations for follow-up surveillance, which I'll go over in a minute. So the consensus guidelines for surveillance and cancer prevention in those with Lynch syndrome are that colonoscopy should be started at no later than age 25. Depends, though, a little bit on how early there's been a colon cancer diagnosis in the family. And it should be repeated every year. While this may seem like an awful lot of colon surveillance, it often results in the complete avoidance of colon cancer in very high-risk people. So from that perspective, one day out of your life for a colonoscopy is invaluable for cancer prevention. Secondly, prophylactic hysterectomy and bilateral, meaning both sides, salpingo-oophorectomy is removing both the fallopian tubes and ovaries. This is a risk-reducing option for women who have completed childbearing. If they're not ready for that surgery, transvaginal ultrasound for ovarian and endometrial cancer can be considered at the clinician's discretion, but it's not nearly as proven to catch these cancers early. In some families, we do see upper gastric cancers. So we generally recommend a baseline upper endoscopy, which is like a colonoscopy, but going down through the mouth, for gastric and small bowel cancers, or somewhere around age 30. And if there's any family history or any signs of dysplasia, that be done on a regular basis. And likewise for urinalysis. So Lynch syndrome is just a great example of awareness being life-saving, since these cancers that are most threatening in this syndrome are very preventable if these guidelines are followed. And what's important to realize is that for every individual who's diagnosed with Lynch syndrome, there usually are, on average, about 10 family members who may or may not have developed any cancer, but may also have the syndrome. And these high-risk individuals can undergo genetic testing, clarify whether or not they have the syndrome and need to be proactive, or gain some measure of peace of mind and lessening of anxiety, knowing that they, even though there's a strong family history, don't have the same risks. So I'm also going to talk a little bit about the hereditary breast and ovarian cancer syndrome, or HBOC, which is caused by mutations or defects in the BRCA1 and BRCA2 genes. Women often come to genetic counseling and say to me, I want to find out if I have the breast cancer gene. Well, the fact is that we all have the BRCA1 and BRCA2 genes, one copy from each parent. These genes play a very important role in protecting us from cancer by regulating the cell cycle of growth and division, and by keeping our DNA in good repair. They're in a class of genes called tumor suppressor genes. It's only when one of these tumor suppressor genes has a defect or a mutation that prevents its normal function that one's risk for certain cancers increases. Women with BRCA1 or 2 mutations have a much higher risk of developing both breast and ovarian cancer, and they're often diagnosed in their 30s or 40s, although it can occur later in life, and the diagnosis, age of diagnosis varies a lot from person to person and family to family. Males who carry BRCA2 mutations are primarily at higher risk for prostate and male breast cancer, and both genders have some increased risk, although again it varies from family to family, for pancreatic and melanoma. I think I'm going to get a quick sip. So HBOC should be expected if you have any of these indicators in your family or yourself. Ovarian cancer in yourself or a close family member. Since ovarian cancer, as Dr. Lerner mentioned, is a very rare cancer with a general population frequency of only 1%, 1.6%, but in HBOC, the lifetime risk of ovarian cancer can be as high as 45 to 60%. Any patient who has a personal or close family history of ovarian cancer should be referred for genetic counseling, regardless of age. Early age of breast cancer diagnosis, especially if prior to menopause or age 50. Family history of both breast and ovarian cancer is a strong indicator, but if the family is small or the health history is unknown to the patient, we often have to look for other indicators. It's important to remember that family histories does not just mean the mother's side. Half of women who carry BRCA1 or 2 mutations have inherited the mutation from their fathers, and their fathers, if they've developed anything, it's usually just prostate cancer, but more often, fathers who carry BRCA mutations are silent carriers. So it's important to count when you're looking at your family history, paternal aunts, paternal cousins, paternal grandmothers. Bilateral breast cancer indicates that more than one independent cancer has developed, which is much more likely if the person has a hereditary predisposition. And BRCA1 and 2 mutations are much more likely in individuals who have Ashkenazi Jewish ancestry. It can occur in any group where there's been reproductive isolation for centuries. So in addition to Ashkenazi Jews, there's a higher incidence of BRCA mutation in the Icelandic population and the Dutch population. Any history of male breast cancer in the family. The risk of developing male cancer is significantly increased with BRCA2 mutations, but is very rarely seen with BRCA1 mutations. So people often ask me, is it true that cancer genes can skip generations? Oops. Oh my God. The answer is that the genes themselves can't skip generations, but some people can carry a mutation in a cancer gene without developing cancer. And of course, the example I've given you of the silent male carrier is one of those examples. Sometimes it will be a female, though, and sometimes it's because they have other modifying genetic factors that make them more resistant to cancer. Sometimes it's because of gender-specific gene expression, like with the male carriers of a female cancer predisposition, and sometimes it's just plain luck. This is the pedigree of a young woman who was referred to me after she developed ovarian cancer at age 47. She has no family history of breast or ovarian cancer, so you might not think she has any hereditary risk for these cancers. And at first look, it looks to be a sporadic case. But if we take a closer look at her father's side of the family, we can see that because her father has no siblings and neither does her paternal grandfather, it makes it kind of unlikely that if there were a BRCA mutation on that side of the family, that anything would develop. So it's possible that there might be a BRCA mutation being passed from grandfather to father and eventually to our patient. And this is exactly what we discovered had happened. Our patient tested positive for a BRCA1 mutation, which has fewer effects on males than BRCA2. And since her mother subsequently tested negative for the mutation, we can assume that it was paternally inherited. So keep in mind that paternal inheritance of a predisposition for female cancers often manifests as a negative family history, especially in those smaller families where there aren't a lot of paternal aunts or cousins. Part of my discussion with any patient who's thinking about undergoing genetic testing for hereditary cancer is, how will a positive test result affect your medical management? What options would you have to lower the chances of cancer development, and are those choices you're willing to take? So the measures that are given to any woman with hereditary breast and ovarian cancer syndrome will depend a lot on individual factors such as what stage of her life she's in. Has she had her children yet or not, for example. But they basically fall into three categories. The first is increased surveillance, beginning breast self-exam and clinical exams at earlier ages, and combining mammograms with breast MRI on an annual basis for early detection of any abnormality. The second are risk-reducing surgeries, which can address the risk to both ovaries and breasts. Since we don't yet have a good way to detect early-stage ovarian cancers, ovarian surveillance is not a very effective way to detect early cancers in these women, although we will do it if the woman is still wanting to use her ovaries to have children. But as soon as she's done with that, we do recommend removing the ovaries and fallopian tubes. And this procedure has two important effects. Not only does it eliminate the risk of cancer developing in the ovaries and fallopian tubes, but if you remove the ovaries in a premenopausal woman, it significantly lowers breast cancer risk. And this is true whether or not you give back low-dose hormone replacement so that the woman does not go into a sudden surgical menopause. Okay. Prophylactic or risk-reducing mastectomy is an option that many women with BRCA mutations choose, both because it lowers the risk of a breast cancer the most, more than any other measure, and because it results in significant peace of mind and freedom from anxiety. But clearly it's not the only or best option for every woman. Chemo prevention means taking drugs to reduce cancer risk. Women who have HBOC and who are not ready to have children or are between pregnancies are encouraged to take oral contraceptives, as Dr. Lerner mentioned, to reduce the risk of ovarian cancer development by reducing the number of ovulations. Chemoprevention of breast cancer usually involves taking a drug that reduces the exposure of breast cells to estrogen, which is known to stimulate the growth of breast cells. So I'm probably running out of time, and just to summarize, a family history of ovarian, endometrial, colon, or breast cancers can be an indicator of a hereditary cancer syndrome, and the value of finding out if you have such a syndrome in your family is that you are then given the options to be proactive and reduce your risk by taking those proactive measures. Thank you.